Thanks, Tamara. When I was asked to speak today, I thought I'd pick a topic that was relevant to everybody because this is a conversation I have in practice almost every day with patients. I've got patients who are keen to have their snoring managed. I've got patients who aren't keen to have their snoring managed and they're there really just so that they can tell their partner that they tried something. One of the diagnostic signs is if a fellow comes in on his own and sits in the chair and slouches a bit, well, I'm going to have trouble getting him to do anything more than that visit. But on the other hand, when they come in and the wife walks in with him, sits at the front of the chair, leans on her elbows on the front of her knees and looks at me like this, I know that we mean business. So I thought I'd break today's talk up into dispelling the rumours about why patients feel that it's really just an industry, and unfortunately the snoring and sleep apnea industry has done it to themselves in that a lot of patients are they're very cynical and suspicious that we're just trying to sell some sort of treatment. So we've now got 20 or 30 years of good evidence behind why we treat and when we treat, and I'm also going to hopefully crystallise in everyone's mind why we don't treat and when we don't treat. So I'll start by breaking the talk up into why do we actually snore. There's the cartoons that we all grew up with used to show somebody snoring through their nose, and yes, nasal obstruction can cause noise, and it does actually cause snoring, but it's not the root evil when patients have sleep apnea. Now the difference, just because I'm talking to an audience who aren't doctors, the difference between snoring and apnea is nobody in the room is snoring at the moment, at least I hope not, I've only just started talking. But I think once the tissues at the back of the neck start to relax and the diameter starts to close, that encourages a little bit of turbulence when we have more air than the available diameter for the tube it's passing through. That disturbs laminar flow, and then we start getting turbulence and rattling, and that's snoring. And then when the amount of reduction in diameters become more constrictive, that's when we start to compromise airflow, and that's when we start picking up what the doctors refer to as apnea. But more precisely, and I know everybody gets excited by anatomy, so here we go. The problem is that most of the apnea, and you'll hear me throw the term apnea in, you'll hear me throw the term snoring in. Simple snorers don't necessarily need to be treated unless they're about to succumb to a pillow in the middle of the night. It's really only the ones who have significant apnea that we need to treat. So the main problem is here, and we refer to this area as the pharynx. So the pharynx is really the back of the nasal area, the back of the oral area, and the lead into the top of the voice box or the larynx. So medically and scientifically, we break it up a little bit further. We have the nasopharynx, and now for all of those people who've talked about adenoids in their lives but don't exactly know where they are, this is where they are. They're at the nasopharynx. So no doctor can see an adenoid. We can just assume it's there by the sound of how the child with a repeated ear infection is breathing and sounding, but you can't see it until you pass an endoscope. Then we have the second area, which we refer to as the oropharynx, and in the oropharynx is where the tonsils live, 2 golf balls either side of the throat. And anywhere in the pharynx or the entire pharynx is the area that constricts and compromises airflow and actually causes our airflow to go from laminar flow to turbulent flow, noise, rattling, and then as it progresses we're into apnea. And one of the biggest areas is this area here, which is behind the soft palate. We refer to it as the velopharynx. And there's the soft palate viewed from the front. So the question is, why don't we snore while we're awake? There's a number of reasons. One main reason is that we have a series of muscles that hold the pharynx open in wakefulness, and these muscles will relax during sleep and relax further when you go into deeper sleep that we refer to as REM sleep. The other reason is that we're talking about the collapse of the pharynx, and while we're all sitting upright, our body weight and our neck weight is dragging vertically down, so it's like stretching a rope, and so the rope's less likely to sag. But the minute we go from sitting upright to then lying down, the muscles push in the other direction, and then that tends to promote more collapse or sagging of the area that we all know as the pharynx now. Okay, so muscle relaxation around the throat and pharynx. The tongue falls back. So a lot of the time, the patient will be sleeping on their back and the tongue falls back, and that helps obstruct. And then there's body weight and neck fat all pushing in on the area of the throat or the pharynx. So here I've got a little drawing where the person at the top is breathing normally. The one in the middle is, has a partial obstruction, bit of turbulence, but the one at the bottom has actually progressed to apnea. And this is why we snore, and this is why we progress to apnea. So the next question is trying to tease out who needs treatment and who doesn't need treatment. And the unfortunate thing is, in the past 20 or 30 years, there's been the rise of a business model where patients are encouraged to have a sleep study. They're taken away from their GPs because the GP doesn't know a lot about sleep. And these business models find a little bit of apnea, realise the patient has a pulse and a wallet, and then tries to sell them a CPAP machine. But fortunately, I think as we've progressed through the ages, there's less and less of that going on now, fortunately. So the first reason that we have to actually buy in and treat the snore is that if we've got a disharmony in the bedroom, that's a good reason to treat it. The second reason we've got is there are health risks associated with sleep apnea. I'll just quickly run through a few of those. And the thing about sleep apnea is it's not as simple as you're not getting enough oxygen. The oxygen that you get in your blood from breathing is really about a quarter of the problem. Probably 3/4 of the problem is what happens in the chest when the chest expands to suck air in, but it's blocked here. So then what happens is gastric contents are sucked up, so these people often wake up with reflux. The other thing that occurs is more blood is sucked in through the big veins, which stretch the heart muscle, and there's a physiological effect that occurs as a result of that. And if any of you have had severe apnea, you'll probably remember waking up in the middle of the night to pee, and then once it was corrected, that problem went away as well. And the reason is that as the heart muscle stretches with this extra blood that it's sucked into the chest cavity, that's interpreted as a rise in blood pressure and release of diuretic hormone, bladder fills up. So these patients often go to the toilet a lot at night to pee. They also have high blood pressure. So there's a physiological effect where certain hormones are secreted which promote high blood pressure during the day. And you see them when you fix their apnea, their blood pressure can improve. There's a higher incidence of heart attacks, rhythm disturbances and atrial fibrillation. I'm sent a lot of patients from the public cardiology clinic locally in our area because they don't want to try and deal to reverse with rhythm disturbances and atrial fibrillation patients until the sleep apnea is corrected. There's a higher incidence of stroke, lung diseases. That probably about 1/4 of the patients who have untreated sleep apnea will develop what we call pulmonary hypertension or raised blood pressure around their lungs, which affects long-term lung health. The ophthalmologists are sending me a lot of patients. There's 7 or 8 well-known eye diseases that mandate that we reverse the sleep apnea. Type 2 diabetes and insulin resistance. There's been some good studies that show that insulin resistance is higher in patients with untreated sleep apnea, even corrected for the obesity. Understanding that as we go higher in the BMI or the obesity number for patients, we tend to accrue a lot more patients with sleep apnea. But they've done studies that have actually separated the difference of the effect of just the weight versus the actual sleep apnea. Mild cognitive impairment is improved by better ventilation overnight and better oxygenation of the brain tissues. And we're not really sure if it's just the oxygenation or the fact that the better quality of sleep is helping drain the waste products of the neuronal pathways in the brain while they sleep. Sudden death. Now, the incidence of sudden death in untreated sleep apnea, I tell my patients that I try not to trivialise the disease, but on the same basis, I don't want to scare patients. And there are patients wives or even, let me say, partners sitting there watching their other partner until they breathe. And if they don't breathe, they push them and they're terrified that they're going to die. Now, sudden death rates in the untreated sleep apnea group are probably 2 or 3 times the normal population's rate, but the rate of sudden death is extremely low in the community, and if you double a rate of 0, it's still pretty close to 0. So I'm not really worried that they'll die in their sleep. What tends to happen is as the oxygen levels dip and the carbon dioxide levels rise, there's an area around the brainstem that picks up the difference in the oxygenation, takes you from a very deep sleep to a less deep sleep to a deep sleep. So they have a disturbed night's sleep that they're not aware of. So these patients will come into me and they'll go, I don't have sleep apnea, doc. I sleep like a log. I put my head on the pillow and I'm asleep straight away. And when the reality is they're probably so exhausted as courtesy of their sleep apnea, that's why they've got that talent. The other thing I'll point out is that we've done a lot of studies over the last decade that have kind of concluded that it's all well and good to see people with sleep apnea and fix it, but you've got to ask yourself, by fixing it, am I achieving anything? And so we went through a wave where everybody with a bit of sleep apnea who was still alive, we'd try and fix them. But now we've got some good studies that show that taking somebody with mild sleep apnea and trying to treat them doesn't necessarily fix it. This is an improvement curve. So you can see if you're down towards the left, if you have no sleep apnea, clearly there's no point in trying to treat it because you don't have the disorder. If you have mild sleep apnea, again, we haven't shown that treating the mild or the moderate person achieves a lot. It's when you get towards the right that we start to see an improvement in health outcomes. And so from a medical point of view, what compels us to treat patients is if they have moderately severe or very severe sleep apnea. And I tell patients because a lot of them are combative, they don't want to be treated. They're young, they've got bad apnea, and I tell them, look, it's a bit like smoking. I'm basically telling you to stop smoking. If you don't stop smoking, you won't die tonight in your sleep. But the minute you have your first heart attack, you're going to have a cardiologist in coronary care standing at the end of the bed saying, why didn't your dickhead doctor fix the sleep apnea? Just like he would say, why didn't the doctor stop you from smoking? So it's kind of a bit like that. So it's not an impending danger, but it's just another health risk that we need to avoid. So this is the group that I tend to treat, and I tend to not treat this group. Unless, of course, they've already got one of those health disorders. So someone's come in, they've had their first stroke, or they've got a problem with perfusion of the retina in the back of their eye. So I'll probably come down the curve a little bit and treat people down there. But again, I don't force treatment on the people down the left unless they want treatment. So that gets me to the second reason why we treat people. Third reason, I mean. So energy levels tend to improve further down the graph as opposed to the health outcomes. So if I've got a patient that's exhausted, I remember 30 years ago in practice, we had a hell of a lot of what people refer to as chronic fatigue syndrome. It's turned out that 2/3 of them were just sleep apnea that were never managed. And since the intelligence around the condition has progressed, we've been able to take these people who come in and they're exhausted and give them a new lease of life. So I'm forever trialling treatment with people to see if they feel better and telling them, look, why don't you just try it if you feel better? And some of them come back and don't feel any better. Some of them come back, feel fantastic. I had one this morning that he only had mild sleep apnea, but he tried a CPAP machine for a couple of weeks and came back and said, I've finally been able to study. I wasn't able to study. This is a young fellow. So the treatment curve, you tend to get benefit further down the curve. Okay. So at that point, I'll now go on to the treatment options that are available. But does anyone want to ask any questions? There's going to be a lot of questions today.
Yeah, I use a CPAP machine, and my readings I get about 5 events
per hour. Yeah.
Is that normal with the CPAP machine?
Less than 5 events is considered no sleep apnea. So if someone has 6 events per hour, they've now become mild sleep apnea. So you're right on the cusp.
Okay, I'm using the CPAP machine.
Yeah. So what I'd advise someone like you is that you've got to use it. You've got to be a little bit human with how we treat people. I don't chase therapeutic perfection at the cost of comfort, Because if the patient's not comfortable, they're just going to put it in a cupboard. So if it's easy to increase the pressure or make it, a lot of patients out there are going to these places that don't involve doctors. So they get these auto machines, and the auto machine tries to keep up and work out what pressure you're going to need, and the person selling it to you doesn't have a physiological understanding. And so they don't follow up with oxygen levels overnight. They don't do any of that sort of stuff. So if you're on an auto machine, the first thing I'd be saying is maybe put it on a constant pressure. And that'd be the advice I give that patient. I'd work out where the auto machine likes to be, and rather than it going up and down in pressure, I'd just set it to a constant pressure. You'll probably find you feel better, and you might get your 5 down to a 2. But 5's not too bad anyway. So if you feel okay and I'd have to see your sleep oxygen levels overnight, which my guess is aren't being checked. But if they were okay, then I'd say it's probably all right. Yep.
Hi. What is, you say event. What's an event? Is that when you stop breathing?
Yeah, so there's a complete apnea, which is no airflow for more than 10 seconds, and that's what the sleep study picks up. And then we have a hypopnea. A hypopnea is where there's a greater than 30% reduction in airflow for more than 10 seconds, but it's got to be in association with a change from the sleep stage, from a deeper sleep, because they check your brain waves as well during the sleep study, and we get to see whether or not you've been in deep sleep or less deep sleep or REM sleep or whatever. And if there's a change in sleep, in sleep staging in association with a reduction of flow more than 30%, we consider that an event. Or if there's a drop in oxygen level, I think by 2 or 3%, if that drops by that much in association with a hypopnea. Hypopnea is the term we use for not quite blocked completely. So we then bundle those up together, and that's what I'm referring to as events.
Was there any other? I see a hand come up there. Here we go.
You might cover this one in the next one, treat options, but I'm wondering about pillow sizes and heights of pillows and lying on sides, that sort of thing.
Yeah, look, that's something there's no good evidence around that. Everybody's anatomy and their necks are a bit different. If someone comes to me and says he sleeps like a truck, but when I use this pillow, he snores like a truck, but when I use this pillow, he never snores, my answer is, well, let's do a sleep study with your new pillow and we'll see if it works. So that's what I'd be suggesting. So I don't have a pillow I can pull out of my cupboard that I know will fix apnea. And then the trouble is, it's a lot of patients come to me and they say, oh, I've heard of laser, or I've heard of this. We all do it. I mean, I do it a little bit too. We all gravitate to solutions that we like the sound of, right? And not many come in and say, oh, I love the sound of that CPAP. Can I have that? That's not often how it starts. But you'll see in this, you'll see there's a lot of areas where the anatomies that's causing the problem can be found. Then you've got to go and target that. So you can't really go to the treatment end and say, well, I like the sound of that, I think I'll do that. You've got to actually wind back and decide which one of the options that are going to work do I like, not which option do I just like the sound of, because it might be useless. For example, if you snore as much on your back as you snore on your side, I wouldn't be telling that person to use a positional device to make them sleep on their side. You know, it's like patients say, oh, look, they'll come in and they'll say, I know what I've got to do, I've just got to put a golf ball in the back of my shirt. And I go, well, mate, you snore just as much, your apnea was just as bad on your side. Tell your wife you're going to sleep on your side and ask her how she feels about the snoring. And yeah, often the bed partner is a good ally for me. Okay, so treatment options. Yeah. You got caught with?
The floods, we didn't know whether electricity was going to come back on.
Yeah.
And I've been really comfortable with this CPAP machine, and I really love it.
Yes.
I get beautiful sleep. Imagine,
Yes.
I'm a privileged bloke. But that night, I thought, oh, the bloody power will come back on. It'll come back on. But it didn't. And so I went 4 nights without it. Now, in that, is that my brain half tricking me because of the power's off? I didn't have a little 12-volt battery, whatever. What is it? That's me. I felt uncomfortable sleeping without it.
Oh, it might just be. It could be the fact that you feel so much better with it. Number
I do.
one, or number two is you're just used to sleeping with it, so you feel like your face is naked. That could be possible too. I don't know.
Yeah,
it
but
could be a
I
thing
felt
you're used to.
A risk factor because look, I've lost a lot of weight, but
Yeah.
everything, the numbers have gone back to me. But I felt real terrible. You know that shit. what you know, what if, whatever, you know, left hand, right hand, what are we doing, you know? Will
The
power
easy answer is, if you love your CPAP machine,
I do.
go back and just keep using it.
Yeah, but I didn't have power over the floods. I didn't know.
Yeah, well, that's okay. If I'm dealing with, say, a bus driver, so he's a commercial driver, right? The driving laws say that they have to use their machine, and we've got to show evidence they've used their machine for 4 hours a night for 5 days a week. So that's not all the time. So you don't have to use the CPAP machine for every single minute of sleep to get the effect. I mean, you really need 4 hours of good sleep, and then you can have 2 or 3 hours of shit sleep as well. And it's still kind of okay.
I just felt uncomfortable.
Has that answered the question?
Yes, yeah. Well, yeah, because I'm so conditioned to it, really, I love it.
Oh, well, I think that, yeah, and I've got a lot of patients like you, and they do love it, and we never ever broach the question of, do I still need it, because they love it so much. Yeah. So, yes, I mean, if I get a patient who was 120 kilograms when I first met them, and now they're 80 kilogram, and they ask me, do I still need to use this, we'll repeat the sleep study to get the answer, without the machine on, right? But if they say, I know I might not need it, but I just love it, why? It's not going to hurt them. Except I did read an article the other day about people not cleaning them and picking up fungal infections from an unclean machine. But there's, you know, there are some people that their hygiene really is, you know, they don't touch their machine for a month until something falls apart. You know, and that's, if you keep it clean, you should be fine. Okay, so what we decided was that the collapse of the pharynx was what's causing the apnea. So the treatment aim is to increase the diameter of what we're trying to force air through. So one treatment option is weight loss. Now, weight loss doesn't mean, for every 10 kilograms of weight loss, you can halve the amount of sleep apnea. So I've got some people who weigh 65 kilograms, they've still got bad sleep apnea. So it doesn't mean just because you're skinny, you're not going to have it. And I've got a lot of people who are 120, 130 kilograms and don't have any sleep apnea. They just snore. But certainly, taking weight off will reduce the amount of pressure on that neck to make it collapse. So you do have a lot more overweight people snoring. CPAP therapy. Let's talk about CPAP for a sec. I was talking to a couple of dentists who were just earlier today, and they said, "Oh, look, we see patients with their they kind of come to us at the end of the treatment cycle, and we're trying to pick up the ones that can't be fixed with CPAP or can't tolerate or whatever." And I think that's a shame, because the whole treatment paradigm is what I refer to as, it's a bit like going to the shop that only sells hammers. If you walk into that shop, regardless of what you need, they're going to treat you like you're a nail. And so the problem that's happened with CPAP is that if you go to a CPAP place, they're not likely to recommend you go to the dentist and get a mandibular splint. Likewise, if you go to the dentist, he's probably not going to recommend that you need a positional device because they read the sleep study, or that you might need some surgery. So you need to be unfortunately, we're at a stage where there's not a lot of people who do all the treatments and just select the right treatment for the right person. And unfortunately, that's the way it's got to be. So CPAP therapy. CPAP therapy, one thing about CPAP therapy is it doesn't seem to be particularly popular in the 20 to 40-year-old dating scene. So that's always a group I have trouble with. But what it is it's 100% successful. So if you can tolerate CPAP, we can cure your sleep apnea. It's not a respirator. What CPAP does is basically just a throat inflator. So it's enough pressure to inflate the throat, and because you're breathing against a head of pressure, the throat at the back doesn't get a chance to collapse. So I'm forever trialling. I'll probably trial about 4 times as many CPAP on patients as actually end up on CPAP. And I often do it just to get a quick answer of whether or not this mild or moderate apnea that we're seeing is behind the actual tiredness. And if it is, then we sit and explore what the options are that are available to the patient. But as a general rule, the heavier the patient, the more likely you're going to have to go to CPAP, because I always like to see one spot in the pharynx that's constricted, but when I see the whole pharynx collapsing in because it's being inundated by the fat in the neck, they're the people that are more likely to need to have a CPAP machine. You'll hear people using the term CPAP as the gold standard. I struggled over why they used to say that, but I think the reason is because it's just 100% successful. So if everybody gives a sleep apnea patient or a snorer CPAP and they tolerate it, problem solved. So that's why it's got the reputation of being the gold standard. Problem with it is not everybody can do it. Okay, so that's CPAP and weight loss. The next thing, let's talk about mandibular advancement splints. There's a lot of patients who respond well to the mouth guard or mandibular advancement splints. So there's one of them there, but they come in a lot of different shapes and sizes. They basically pull the jaw forward and open up the back of the throat. So if we can pull that forward, we're pulling the tongue forward, we're pulling the tissues of the pharynx forward. The other thing that's happening is it also seems to pull forward the part of the vilopharynx, remembering the vilopharynx was the bit behind the dangly thing at the back, or the uvula or the soft palate. So it does do that. The other thing it does, which people don't calculate, is that it actually stretches the tissues. So remembering that stretch of the tissue improves the stiffness and rigidity, so it's less likely to collapse. So I do all these tests in my rooms where I've got an endoscope in the back of the throat, and we get them to jaw thrust, and I just get to see whether or not it's likely to work and what tissues are in the way. The other thing I get is a lot of patients who say, hey, I bought this boil and bite thing from from some shop somewhere or some chemist, and I think it worked, and then it's not working, and it was probably hopeful thinking in the first 2 weeks of it, and now the truth has come out that it's really not working. And so what I do is I get them to clip it in while I'm looking at the back of their throat, and I can see what it's doing to the diameters at the back. You need to get a decent mouth guard, so you need to actually see a dentist, and the dentist will take an impression. It's expensive. It's probably, in a lot of areas, dearer than buying CPAP. And patients recall a little bit of that. Some of the CPAP, some of the mandibular advancement people will offer a refund if it fails. But, certainly the dentists I refer to, if I've examined them and sent them along, they know that not many of them are going to work, because I don't just send everybody along. I just send the ones who are more likely to work. Positional therapy. So some patients, you read their sleep study, and a lot of the times the people at the CPAP shop and the GPs a lot of GPs unfortunately don't know their way around a sleep study report, and so I spend a bit of time lecturing to the doctors as well so that they can understand it. But sometimes you see patients where all the apnea happened on their back but none of it on their side. So there's devices you can get. This business of sewing a golf ball in the back of your shirt, I don't know anyone who 6 months later still sleeps with a golf ball in their shirt. So it's just crap that keeps the bed partner happy and they get out of my room. But there's devices around such as this one where it sits like a wristwatch on the back of your neck. As soon as you go onto your back, it starts vibrating, wakes you up, makes you roll over, retrains your sleep. It also has a decibel meter in it, so it picks up how much snoring is going on, and so I'll often trial them on it to see if they like it. I had one the other day where a lady wanted to buy one. We just trialled it to see if she could stand sleeping on her side, and she loved it, and so it worked. Now let's talk about surgery. I get some patients that come in and say, oh, just give me the operation. I go, oh yeah, what operation were you thinking about? Because the trouble is there's a whole number of operations, a whole number of things that are going on. It's not like we've got an operation that works. And the operations that we do have, if we're lucky enough, say that somebody's got big adenoids and we can take it out and that can fix it, then that's great, that's likely to work. On the other hand, if I find big tonsils and I take those out, that's likely to work. But when everything's just collapsing in, there's not a lot of good operations to solve the snoring and the apnea. They do have an operation that they work on the back of the tongue. So some patients have the tongue-based prolapsing back, and you can see it when you're scoping and you're behind the tongue. You can see the tongue's imposing on the space, and they've got this procedure where they vaporise little channels in the tongue, and then the scar tissue scars the back of the tongue away from the back area, and that can work in that patient. But you can't just walk in and say, I want to have the tongue coblation, because your tongue could be nowhere near the problem. A lot of the problem is the vilopharynx, and they did have an operation where they did something to the soft palate, and we still do it. I still do it now for simple snorers, but I've got to say in probably 2,000 or 3,000 snorers that I've dealt with, I reckon we've done this operation about 4 times. If we and I'm waiting for the person that comes in that's unhappy, because the truth is, that operation, if you do it 20 times, you're not going to have 20 patients shaking your hand at the end of it. There'll be some that want to kill you, and there'll be some that have got a great result, most of them, because we select who we do it with, but there are some that you don't get the result and they're a little bit uncomfortable. Sometimes you get the odd one where food goes up the back of their nose, because you can see the palate is a curtain that helps you swallow in the right direction. And so if you go chopping that away, sometimes there's a little bit of food that goes up the back. But one thing that operation does offer is it takes away the length of tissue that's going to vibrate and make noise. And so that's probably the end of my surgical discussion, and that's the end of my talk. So I'm happy to take more questions if we've got any more.
Anybody? Yes, we've got one up the back.
Hello. I'm actually from a sleep clinic, and quite a bit of your generalisation about CPAP outlets is a bit negative. Do you admit that there are some out there, hopefully we're one of them, that actually does all the reporting and all the scoring and all the supplies is in an honest and probably proper structured model that utilises sleep and respiratory doctors?
Yeah, and I apologise to you if it sounded that way, and I guess it did. But yeah, and the answer to your question is yes, I do. There are some good sleep outlets, but the problem with the sleep outlets is they do defer immediately usually will defer immediately to CPAP. Is that an incorrect statement?
No, we follow the guidelines, and Medicare have changed the rules lately, and now the new rule is that if someone's diagnosed with sleep apnea, they're actually, the study is reported, it's scored by a scientist, then it goes to the sleep doctor, then we get the results, and now the new rules are that actually the patient gets referred back to their GP to discuss their results. After the GPs discuss the results with the patient, they then come back to us for treatment. So the industry over the last few years has had radical improvements, and yes, there's a few cowboys still out there, but there are a number of good, reputable places out there that have done the right thing and follow all the guidelines. Yeah,
so that's kind of consistent with what I was saying. It was an old problem that seems to be evaporating now. The problem with just going back to the GP is, they'll almost certainly look at the recommendation. They'll go straight down the bottom, look at the recommendation, which is CPAP, which is not wrong. But it is if it's a patient that's probably appropriate to a splint. And if it's a patient with mild to moderate, and so it's a bit clunky, but there's nothing devious about this, about the way it's run at the moment. It's actually meant in the best, it's got the best intentions.
It's Medicare guidelines.
I know, yeah, I know. I do sleep studies as well. Yeah, so yeah, we know. And it's a lot better now that they're actually doing that, because it. Yeah, I didn't realise that they actually tell you it has to go back to the doctor before treatments.
It's in the guidelines. It says all patients should see a GP or specialist prior to treatment.
Right.
Basically, yes, like you were saying before, there's a lot of GPs that don't know what to do.
Yeah, they don't know. So they just, and they're not going to make a mistake saying have CPAP.
Yeah, so what I typically educate them is to try CPAP. Like you said, you try 4 times. Patients on trials, and they can see if it works for them. Obviously, in regards to their health, over 20 events per hour is where the link to increased heart attack and stroke. And then if it doesn't work, we then send them back to their GP for either a splint or to see a sleep physician. So the processes are definitely there.
Yeah, and that's, you're doing it all correctly. There's not, I applaud what you're doing. But the system is that, so it doesn't work, so what do they do next? Then they go to the sleep physician. What's he going to say? He's going to say, you need, I think they also need to have the endoscopic examination, because you can't dispel surgery immediately. How do you know you don't have a huge set of adenoids? You can't tell that sort of stuff unless, and the trouble is the system doesn't allow unless you go to the GP and he says, well, before we go to the dentist, why don't you go to the ENT surgeon, and then why don't you go, and the trouble is it's a bit expensive for the patient.
Yeah, no, definitely.
Yeah. So it's not a criticism of, it sounds like what you're doing is absolutely correct, but the way the system is, they need more people who who do kind of, examine the patient. And you need to examine first before you determine where you're going to go. But a fair thing is, if you've got a patient who's got a huge BMI and they're desaturating terribly and they're extreme, the first thing of trying CPAP is, and that's I do it as well. They try CPAP and I wait for them to tell me they can't do it before I start scoping them and trying to look for Plan B, which, mind you, is not guaranteed, just like CPAP is guaranteed.
It's a vicious cycle where people can't. It would be ideal if a lot of people could lose weight, but they can't lose weight because they haven't got the energy to do it.
Yeah.
So they've got to break the cycle somewhere, and putting them on either sleep apnea, CPAP treatment, or a mandibular splint. Once you start treating it, quite often a lot of patients then get the energy to be able to exercise and start losing weight and help themselves. But there has to be something that kicks off that breaking the cycle.
I tell patients, we start to talk about surgery a bit, and you can see I use those slides in my practice to try and show patients why we're not just sending you. I'm scared if I send you to the surgeon, you'll end up with an operation. So sometimes I've got to protect patients from the specialist, where they think they want to see the specialist, but I'm not holding them for any personal reasons. It's just I'm trying to protect them. But the most successful operation, I think, that's around for curing sleep apnea is probably bariatric surgery in the people with a BMI over 35. So that's, if you want to pick one operation that's the most successful, it's probably that. Yeah. It's big difference.
It is a huge difference. Everything.
We've got another gentleman
Okay,
here.
yep.
Oh, sorry, I try to be short, but this is a little bit personal experience about this, sleep studies. First of all, for disclaimer, I am a system engineer, so I understand very well about system. My expertise is in risk management. Basically what it is I have a very active life. I do sports every day of the week, including weekends. My weight since I was 17 years old, I used to be a competitive athlete until now, has been between 78 to 84 kilos. I am 84 now, basically. So when I went to this process about a sleep study, my GP straight away, because I said to him, hey, my son told me I am snoring. Okay, let's go to do this sleep study. I went to one of the practitioners, which is basically just a technician dealing with you, and straight away put all the electrodes, sensor, thing like that, which is feel uncomfortable for me. In the morning, half of the electrodes went off because I move a lot when I sleep. Secondly was situation, the normal, I suppose, guidelines is that you should have to have this electrode for 8 hours.
Yeah.
My sleep pattern is between 6 to 7 hours for almost all my life, because I said before, being an athlete, I used to wake up 4 o'clock in the morning to do training, so normally I sleep 6, 7 hours. But at the end of the day, what I didn't like in the systems was the report.
Yes.
It's coming a simple report, okay, you have a severe problem here. Okay, and moreover, and then it's coming a report greeting and signing for, I suppose, a doctor. And the doctor make an adjustment, and we advise you don't drive.
Right.
So straight away for me that trigger a risk problem.
Yes.
Because my insurance, my duty of care with another people, because I drive all the time a vehicle. So I try to contact whoever signed that document. A guy, I never met him, I never talked to me. He didn't know what is my activities. He didn't know nothing about me. And he has to make a statement in a piece of paper, which create a risk for me. So this is the things that basically has to be fixed. It's no Medicare, nothing like that. It is basically a duty of care, whoever is doing, this is why I say unethical as well.
Yes.
How people can sign, especially a doctor, which I suppose you guys has an ethic, can sign a document, because I am based in the index, whatever index what it is, without dealing with the patient.
I'm sure my friends at the back from the sleep clinic would know the answer to this, but I'll take that question. It's a very valid point, and a lot of the times I'm scared to do sleep studies on people because I don't want to uncover things that are going to cause them a problem with their insurance. Now, a couple of points you raised. The first one is the validity of the sleep study. You commented how things fell off and I didn't sleep for 8 hours and how can they... There's certain guidelines that the scientists go through that make the sleep study valid or not valid. And I'll get patients that come in and they'll say, I don't know what you can tell from that study, I didn't sleep a wink. And I go, well, hold on a second, I'm looking at this, you tossed and turned for 45% of the night, so you really had a bad night, but you were asleep for 55% of it. So the bits where you toss and turn, we just chop that out and throw it away. All we're looking at is what's happening per hour while you're asleep. The rules don't necessitate that you have to be asleep for 8 hours. I think it's 4 hours, correct me if I'm wrong. I think you have to be asleep for 4 of the 8 hours, but it's a continuous tracing. The reason it's on for 8 hours is because Medicare won't pay for the study if you're sitting there doing 7-hour studies. So that's why. So there's a Medicare reason. But in terms of, so forget Medicare and the funding, because we're giving these studies to it's an expensive process, and we're giving it to the patient for free. So we're trying to not break rules while we're doing it. But if we've got 4 hours, I think that's enough. You can tell per hour what's going on. So that's the first thing. The second thing is, you're absolutely right. But however, if the sleep physician at the time of reporting it has made the comment about don't drive, and I don't know if it would mean that you had considerable sleepiness on your sleepiness score. And so I don't know what the sleepiness was, but we have a sleepiness score out of 24. Right? So imagine it's out of 24. If you're less than 10, you're considered normal, but you've got to be over 8 before Medicare will pay for it. And if you're 16 or higher, it jeopardises driving. So we have a score that we work to, and my guess is you may have had a sleepiness score of 17 or 18, or the person reporting it has said be careful with driving, and the GP has interpreted that, because the GP just sees severe sleep apnea. They don't know the road rules. The GPs don't know it, so they sit there they take licences off people without that. All they see is severe sleep apnea, and they've taken the licence off because they don't understand what the rules are. And that's unfortunate. And I go around lecturing people and trying to say, look, the Austroads guidelines are a bit complex, and you've got to marry up 2 or 3 different pages in different places, but here's the list. And I give them the list, and I go, they've got to have this or this or this or this, otherwise you can let them drive. So if they don't have that, they can drive. Are you a commercial driver?
No. I am a professional engineer. But I was trying to say as well, I straight away when I read that report, I have a look at the graph. I can read graph. I have seen all my life graph. So the whole problem I got in terms was between 5 o'clock in the morning to 8 o'clock when I was already awake doing things because they told me I will keep this at least for 8 hours, but I already was awake. So everything was red from 5 o'clock in the morning to 8. Obviously, So
you were awake when they were scoring things?
Yeah, exactly.
Oh, well then, I can't. I'd like to think that every sleep. I'm
I'm
sure it wasn't done by our friends over here.
But I told, when I went to deliver the equipment, I mentioned to them exactly what was my pattern, when these things fell off, because I have a good idea. But when they wrote the report, it's signing for a sleep doctor. And so, this was my whole argument. How you can sign something? Do you read my notes when I deliver the equipment? They haven't read the notes.
Yes,
and this is when it should be. I was very close to call to whatever IMA or whatever. Almost.
I don't doubt your story. I'm sure it happens from time to time. But by and large, most of us in the industry, I think we're all trying to do the right thing, and we're doing our best. So you're right. That's an unfortunate experience. And my suggestion to you is get your sleep study repeated and take it to someone who knows what they're doing.
So when you said before, if people can't tolerate the CPAP, is that because they take it off all the time? Or some other reason?
When I'm about to start someone on CPAP, I have this conversation where I say, CPAP's a bit like chemotherapy. No one looks forward to it, but they're pushing through it because they need to get a result. And so a lot of the time, either they take it off or they can't stand it, or they just can't sleep with it on. And some of them reluctantly say, yes, I'll try CPAP. And they'll ring the next day and say, it was a waste of time, you know, but they've got to they've got to acclimatise to it. Everyone's much better at CPAP 6 months after starting than they are 6 days after starting. And I tell them, look, you've got to build up gradually. So why is it? Because they just find it too bothersome, it disturbs their sleep, and they're not willing to put in the effort to get it over the line.
Do you suggest techniques for stopping you from taking it off during the night? Because I have that problem. I take mine off.
Oh, and you just wake up and it's next to you on the bed. Do you know how many hours you get out of the CPAP?
I'm a bit bad. I don't look at the
look
phone
at the thing,
thing
yeah,
to
yeah.
say how many. It's got a phone app, but I haven't logged in to check it yet. But I just keep persevering, and one night it'll stay on all night, and the next night, it's beside me on the pillow.
Yeah, you might find you just get better and better. There is a mask that actually clips onto the top teeth, and it does a U-turn and goes into the nose. So maybe something without a strap might work.
Yeah, because I find it falls off my head.
Yeah.
Probably it's a female.
That mask's called a TAP-PAP, and some people use it and love it. So it's basically just clips onto the top jaw, and the other end is in your nose.
Thank you.
Looks like we've got another one just over here.
No, with her uncomfortable and whatever, I used to feel that. It's just getting the right fit with the mask, and I love it.
Yeah.
I'm getting 100% on that app
Yeah.
daily, and it's like, I'm so happy.
It's a lease of
with that.
life.
It just was the
Well,
right
those
mask.
cradles are meant to hold full face masks.
Yeah.
What about just using a nasal pillow? Because that's
I've
only
got
a single
Yeah,
strap.
I've got the nasal
Yeah,
one,
yeah,
and
yeah.
it's awesome, yeah.
I'll just say a little bit for the CPAP users about the leak, because I get patients coming in all the time and saying, "Hey, why am I getting a lot of leaks? I came in because I got to fix a leak," and I'm only interested in the leaks if one of two things are happening. One is if the leak is disturbing the bedroom because it's noisy, then I'll have to try and do something about it. And the second reason I'll deal with the leak is if it's leaking so much that I'm not getting the pressures in the back of the throat. If I'm not getting those, if I'm finding the leaks frustrating treatment, then sure, I'll treat it. But if my readings of the pressures and the oxygen levels and the number of obstructions, all the rest of it are okay, just look at the red face and don't let it worry you. You get those red face in the morning when you wake up? Yeah.
Is that a true reading? That's what I was talking about.
Is the machine a true reading?
Yeah, well, see the meds. I can wake up and oh mate, brilliant, And that thing says I've had 18.1. No, that's not right. That is not right. I can tell you that now, myself evaluation.
Look, there's an algorithm that it works to, and I've found it. I mean, just my anecdote. I haven't had a reason to question it. I mean, just because you feel good doesn't necessarily mean that. What you might do is, and that might be a bit difficult to do it, but if you're getting 18s, why don't you do a sleep study as well while you're wearing it?
It's only spasmodic. But
Well, is it
I said
accurate?
wing
I can't tell you for sure because I didn't design it, but it seems to be reasonably reliable.
Yeah. No, I don't drink, but no. It's just a rarity. No, I don't drink. Yeah. No. It's just, as I was told, forget it. It's just a red face. It's flying the ointment. Don't worry. You're good. Good to go. I love it. And funny, for those that I've spoke to many people about if you first use a CPAP. Look, I don't drink wine, but wine used to always, when I was drinking beer, wine always made me go doughy at the end of the night. So just hang into the end. Don't go watching drinking coffee. And have a wine, something, and put it down a bit quick because you're going to get. You know how it makes you a bit sleepy.
Yeah.
So put it on, then you forget about all the other stuff, and put a bit of light music on, a bit of panpipes, or I don't know. Put something. You don't want Neil Diamond in there pumping away, crackling Rosie. You won't go to sleep.
I'll tell you a couple of other little pearls. Some patients might have mild to moderate sleep apnea. They feel okay, so I don't really have a reason to treat it. They snore like a truck, but they live in a caravan on their own. So that person, my advice to them is, it's a progressive disorder. As we get older, we're relying on the elasticity of the tissues in the pharynx, in the back of the throat. As we get older, that gets floppy just like everything else does. So if they've had mild to moderate sleep apnea and I'm not going to treat them, the only treatment I give them is come back in 4 or 5 years, let me do the sleep study again. Or if you feel terrible, because this is likely to progress. And when it gets to the point that we probably should treat it, I'll get in and treat it for you.